There we go. Okay, last class, I was talking about cranial nerve number 9 being responsible for innervation of the carotid body. You guys were right. I went back and looked. I did not put it. My apologies. Vague, not good. If we go back to the mixed cranial nerve, this is under function. What should be here in purple, keeping it purple for the solitary nucleus, kind of goes, it's not taste, but it's carotid body. In purple. Yeah, carotid body innervation. Sorry about that. Now, and there was some discussion after class too about what the carotid body actually does. I thought that was a review for you guys. Sorry about that. Do you guys know what the carotid body does? Anybody? Yeah, chemoreceptor, right. So it's responsible for the most part, we're going to talk about detecting levels of CO2 and O2 in the blood. Okay, also detects pH, but for us, CO2 and O2 is fine. Okay, that's the carotid body. And that carotid body is innervated by cranial nerve number 9, the glossopharyngeal. So that should make more sense now than come back. So everybody got that? Any questions about that? What? It is, but it's also carotid body. So it goes along with the carotid body in the taste. There's also something else with the cranial nerve number 10 too. Okay, then let's go back to and pick up where we left off Monday. Yeah, it's only Wednesday. This is the medulla cranial nerve nuclei that we were doing. We made our way through cranial nerve number 9. And that's where we picked up the carotid body, and that's using the solitary nucleus. So in addition to taste, you also have carotid body innervation through the solitary nucleus. Okay, the next one that we have to do is cranial nerve number 10. Okay, and moving on down the line, ideally I would want to put cranial nerve number 10 here really close to cranial nerve number 9, but the way that I've done it, I haven't given myself enough space to do that, so I'm just going to go ahead and put the emergence of cranial nerve number 10 here. Okay, it's pretty close. It's just the next one down. I'm just trying to give us enough space to write things in there. Okay, so this is going to be, this is cranial nerve number 9, this is cranial nerve number 10. And that's going to be your vagus nerve. Okay, is everybody, bless you, caught up? See where I am? Now, thinking about all the things that the cranial nerve number 10 does, if we think about motor function first, what's the motor function for cranial nerve number 10? Does anybody remember? What muscles does it innervate? I'm going to make this. Oops. Hello? Anybody out there? Yeah, great. That's going to be muscles of the soft palate, pharynx, and larynx. Okay, I'm just thinking about function now. Okay, that's going to be cranial nerve number 10. So, and to innervate muscles of the soft palate, pharynx, and larynx, it's going to use the nucleus ambiguus, just like cranial nerve number 9 does. So, neuronal cell body located in the nucleus ambiguus is going to come and be part of cranial nerve number 10, specifically to innervate those muscles, the soft palate, larynx, and pharynx. Okay, when it comes to the dorsal, when it comes to cranial nerve number 10, there's some parasympathetic innervation to heart, lungs, and GI tract. Okay, the parasympathetic innervation. And that's going to have another nucleus. We drew it earlier, and this is going to be your dorsal motor nucleus. And since it's parasympathetic innervation, I'm going to go ahead and draw that here in a green color. The green is going to be your dorsal motor nucleus. Okay, cell body that resides in the dorsal motor nucleus, sends out axons that travel as part of cranial nerve number 10, and this is responsible for parasympathetic innervation of heart, lungs, and GI tract. Cranial nerve number 10, vagus nerve, also has some general sensory function. Anybody remember what the general sensory is? Yeah. So the larynx and the epiglottis. Okay, so we put, and we'll, that's sensory, so I'm going to put that in blue. So this is general sensation. I'll just put general sensory for larynx and epiglottis. Okay, so that's going to be your general sensory function. Talk to that. So the general sensory function is going to be the blue. That travels as part of cranial nerve number 10. And since it's general sensory, it's the same as all the other general sensory, goes all the way up here to the spinal nucleus, so trigeminal and synapses with a neuronal cell body there. Another function of cranial nerve number 10 is going to be taste. And so I'm going to go ahead and use the purple for the taste. So and it's going to be taste from the base of the tongue. It's actually base of tongue and epiglottis. Okay, and since it's taste, that's going to travel as part of cranial nerve number 10 and synapse down here in the solitary nucleus, delivering information about taste. And there's only one more sensory, and then that's going to be that's part of cranial nerve number 10. And that's going to be your visceral, and it's going to be in purple. So it's going to be general visceral sensation from heart, lungs, and GI tract. Okay, so visceral sensation information travels as part of cranial nerve number 10, goes down here in synapses, neuronal cell body in the solitary nucleus. Oh, bless you. 10. 9 and 10 have a lot of stuff going on. They use a lot of different nuclei. I think those are the most complicated ones that we've seen. 7's kind of complicated, 5's kind of complicated, but 9 and 10 have a lot going on. Questions about those? So we taught all the sensory, and then there's one more nucleus, and I'm going to go ahead and put it on this side. Okay, there's one more cranial nerve that we haven't talked about yet, and this is a cranial nerve that's going to come out of the pre-olivary sulcus, and it's going to be cranial nerve number 12. Cranial nerve number 12 is easy. Cranial nerve number 12, that's your hypoglossal, and it uses this great big old nucleus here in the medulla. That is your hypoglossal nucleus. Okay, neuronal cell body resides in the hypoglossal nucleus, sends out axons that emerge through cranial nerve number 12 as cranial nerve number 12, and they innervate tongue muscles. That overall is everything that we need to know. We covered cranial nerves 3 through 12, excluding number 11. So spinal accessory exits through, lives in the ventral gray horn of C1 through C5, and then comes up and lives right about here. Okay, just under 10. Okay, but everybody else has nuclei that reside in the brain stem, 3 through 12, not counting 11. Questions? So I see what happens. You got different nuclei. All these cranial nerves have different functions, and to accomplish those different functions, they use the nuclei that are specific for that function. Questions? We good? Let's go ahead and move on to the next one. And the next one that I'd like to talk about is the sensory pathway for cranial nerves. Okay, and specifically here, think about this being the correspondence to the spinothalamic tract that is responsible for somatosensation. This is going to be responsible for pain, temperature, crude touch for the face. Okay, that's what this is about. So all that general sensory information that we talked about before, I'm looking at sensory cranial nerve pathway. You know, here's my cortical region. These are going to be my thalami. Lentiform nucleus, so putamen, glottis palatis, internal, externus. There's my midbrain, and there's my pons. Okay, so the idea here is we're going to look to see how sensory information comes from the outside, any sensory, general sensory information from the head overall, and I'm going to use cranial nerve number 5 as an example. So go ahead and in the pons here, draw in cranial nerve number 5, the trigeminal nerve. Big old cranial nerve. Now, if it has to do with general sensory information, what nucleus or nuclei are going to be used for any cranial nerve, no matter what? Does anybody remember what that's called? Spinal nucleus and trigeminal, and the main sensory nucleus. Remember, they function as one, and I'm just going to go ahead and draw those in here right now. Okay, so this is going to be my main sensory nucleus, and then here is going to be my spinal nucleus or trigeminal. Great. And I'll go ahead and put in a midline too, because that always helps to see things cross over. Okay, so this is going to be main sensory, trigeminal, and this is going to be spinal nucleus of trigeminal. Remember, these function as a pair. No real difference. If you synapse to either of them, you're delivering sensory information about something in the head. Okay, and I think the last class I talked about there being a ganglion here that lives about the area of your temple, and it's the ganglion that houses the first order neuron, the sensory neuron. Does anybody remember the name of it? It's going to be your trigeminal ganglion. So I'm just going to draw it kind of like we did with the dorsal root ganglia, remember, for the spinal cord. So here's going to be your trigeminal ganglion. Okay. Trigeminal ganglion. And as I said, the trigeminal ganglion houses your first order neuron. And the first order neuron for sensory is going to be that pseudo-unipolar. There's the cell body coming out. And specifically, if we're looking at cranial nerve number 5, we have division 1 for cranial nerve number 5, division 2, and division 3. Okay, so 5-1, which is ophthalmic, 5-2, which is maxillary, and 5-3, the 3 different divisions for the trigeminal nerve. Division 3 is mandibular. Okay, so here's your first order neuron cell body, resides in the trigeminal ganglion. Axons, so dendrites are picking up sensation from 3 different divisions of the face. Axons travel through cranial nerve number 5. And synapse here, either in the main sensory or the spinal nucleus or trigeminal, with your second order neuron. Let me write that down. Here's your first order neuron. Here's your second order neuron. Okay, so second order neuron. What does anybody remember about the second order neuron in a sensory system for the somatosensation? It decussates, yep. So this one's no different. It sends out an axon that immediately decussates to the contralateral side. Okay. That axon travels up a very specific tract. I'm going to write that down here in a minute. And then ascends to the thalamus. I want to write this in here. This tract, and we're going to look at it today. This tract is nothing more than second order neuron axons traveling up through the pons in the midbrain. And this is called your trigeminothalamic tract, right? From going from trigeminal to thalamus. So trigeminothalamic tract. Okay, trigeminothalamic tract just carries information about pain, temperature, crude touch, in any area of the head or face, nose, eyes, all that stuff. Goes up to the thalamus, and in the thalamus it synapses. If you remember STT, what was the name of the nucleus in the thalamus that STT synapse with? Yeah, VPL. So what happens here is it's from the face, so it's a little bit of a different compartment. This is VPM. So ventral, posterior, medial. So it's the ventral, posterior, medial, and this is just a nucleus in the thalamus. So it's VPM this time instead of VPL. Okay, synapses with the contralateral thalamus and the VPM, and that contralateral. That nucleus in the contralateral thalamus sends out an axon that travels over here to the postcentral gyrus and synapses with the facial area on the homunculus. So I'll write in facial area homunculus, and then you put in post-central gyrus. questions? So information coming anywhere in the face travels through cranial nerve number 5. If you're looking at the face area, synapses with a second order neuron that resides in either the main sensory nucleus or spinal nucleus or trigeminal. That neuron, second order neuron, decussates immediately and travels up through the rest of the brainstem as the trigeminothalamic tract. This axon synapses with a neuronal cell body in the VPM of the thalamus. That third order neuron, again, this is your third order neuron. Okay, that third order neuron sends out an axon that goes to synapse in the area of the face for the postcentral gyrus. Yes, Pat?
You said, what was the name for V1, V2, V3 again?
Oh, okay, I can write that down. Not a lot of space, but I'll tell you what, I'll write it over here. That way there's more space and you'll be able to see it better, okay? So V1 is ophthalmic. V2 is maxillary. And V3 is mandibular. And I think about it as V1, if I take my 3 fingers, I can put my third finger on my jaw, my second finger on the maxilla, and the top finger is up at my forehead or eye region. So 1, 2, 3. That's how I remember it. Okay? Does that make sense? So ophthalmic, maxillary, mandibular. Okay. And there's some, in the slides presentation, there's some, kind of a nice picture with shading of the 3 different areas. But you should just know that those 3 different areas exist. Why that's important is you want to make sure that you're touching all 3 areas when you're testing for the trigeminal nerve. Any other questions? Does that go? No? Everybody good with that? Okay, let's go ahead and move on then to, so this is the sensory cranial nerve pathway. In addition to the sensory cranial nerve pathway, we also have the motor cranial nerve pathway. So moving on here. So sensory cranial nerve pathway, as I said, has first order, second order, and third order neurons. Second order neuron, as you'd expect, decussates. It's nothing different. The one big difference is it's going to synapse and thalamus, the VPM, as opposed to the VPL. But kind of a similar pathway. When talking about the motor cranial nerve pathway, it's also very similar to the motor neurons that we've talked about for the rest of the body, because it's a first order, it's an upper motor neuron and a lower motor neuron, and that's it. Okay, so the upper motor neuron, just like normal, starts up here in the precentral gyrus, okay, and then sends down axons that synapse in the nuclei, the nucleus of the cranial nerve that has the motor activity associated with it. Okay, so it's just the nucleus. The nucleus and the nerve that comes out of the nucleus are the lower motor neurons. Okay, that's where the lower motor neurons. Everything above that's going to be your upper motor neuron. And to make it, let's go ahead and look at, we can do, let's do 5. So as far as motor function for cranial nerve number 5, if we stick with the trigeminal nerve and think about the trigeminal nerve that we just drew, it's a mixed cranial nerve, right? It has a motor and a sensory function associated with it. Okay. So this is going to be, again, my trigeminal nerve. So is there a question? No? So this general pathway is going to exist for all the motor cranial nerves except for cranial nerve number 7. That one's a little bit different, and that's why I'll cover that in the next slide. But for right now, all these other cranial nerves have the same pathway. So this is going to be my cranial nerve 5, which is my trigeminal. Okay. Thinking about motor function. which nucleus is cranial nerve number 5 used for motor function? Does anybody remember? Good. So you're going to have your motor nucleus of trigeminal. It's going to be, I'll just put it right here, and it's going to be bilateral. So your motor nucleus of trigeminal. Okay. Takes care of my bottom part. And then inside the motor nucleus of trigeminal, bilaterally, I have a neuronal cell body here and a neuronal cell body here. And as I said, this is the lower motor neuron that sends out an axon through the cranial nerves. Okay, and this lower motor neuron, this is going to be my lower motor neuron right here, bilaterally. Both the neuronal cell body and the axon that's coming out as a cranial nerve. It's going to innervate, what does it innervate? What's cranial nerve number 5 motor activity? Muscles of mastication. Temporalis, masseter, medial lateral pterygoid. So everybody got it? See what's happening? Now for the tricky part. So we have a neuronal cell body. So up here in the precentral gyrus or primary motor cortex, there exists a neuronal cell body bilaterally. This is going to be your, pull down, sorry, thank you. This is going to be your upper motor neuron. See that? Okay, so this is going to be, this is facing forward, so this is going to be the right side over here, and then this is going to be the left side over here. Okay. The upper motor neuron on the left side, right here, is going to come down, travel through that internal capsule space that we talked about before. It's going to come all the way down and synapse ipsilaterally on the lower motor neuron, as well as once it gets to the level of the dorsal motor nucleus, the motor nucleus of trigeminal, it's also going to decussate at the level of that nucleus and synapse with the contralateral lower motor neuron. Everybody got that? Does everybody see that? What's happening there? So I've got innervation. So both sides are actually innervated by the upper motor neuron on the left side, as well as the upper motor neuron on the right side. The same thing happens here on the right. So that sends out an axon, travels through the internal capsule, synapses ipsilaterally with the lower motor neuron, and at the level of the motor nucleus of trigeminal, it also decussates at that level, goes to the opposite side, and synapses with the contralateral lower motor neuron. Did you have a question, David?
So if you had a lesion of an upper motor neuron on the right or left side, it wouldn't affect.
That's the point. Good job. That's it. So everybody got that? So this is true for the majority of the cranial the cranial nerves with motor function, except for cranial nerve number 7. We're going to talk about 7 here in a minute. That one looks a little different, okay? But in general, when you have a cranial nerve upper motor neuron traveling down, this tract has a special name. So before it was the corticospinal tract, when we were going all the way from the cortex all the way down to the spine. Now this is going to be called the corticobulbar. So this is the corticobulbar, B-U-L-B-R tract. Okay, that's your corticobulbar tract. And it's bilateral, both on the same side.
What did David say? Like just to see.
Yes, I'm going to talk about that in a minute. That's it. And so the main point to know for the majority of cranial nerves, except for cranial nerve number 7, is if you have a lesion that has affected this upper motor neuron on the left side, that upper motor neuron could be completely gone. You're still going to get function of the for your muscles of mastication, because there's an upper motor neuron on the opposite side that's going to come down, innervate ipsilaterally and contralaterally. Does everybody see that? So it's kind of rare to have an upper motor neuron presentation for cranial nerve, because most of them are innervated bilaterally. You really see not that much of a difference. There's a few weird exceptions. We're PTs, we don't worry about that. Okay, but for the majority of them, except for cranial nerve number 7. Does that make sense, Alyssa, when I say that? Does everybody see that? So all your motor nerves are innervated bilaterally. And instead of like corticospinal tract crosses over at the level of the medulla, corticobulbar tract crosses over at the level of the motor nucleus that's synapsing with. So for example, if you had cranial nerve number 6, you'd come all the way down to abducens nucleus before you cross over. Okay, it's going to be true for everybody all the way down. Questions? Okay, then let's look at the outlier. The outlier here is going to be your facial nerve, or cranial nerve number 7. And this is just differential diagnosis for cranial nerve. So the idea here is that you're going to try and differentiate between a person who's had Bell's palsy versus a person who's had an upper motor neuron lesion, most commonly due to a stroke. Does anybody know anybody who's had Bell's palsy? Yeah? Okay, how are they doing? They doing okay? Everybody's better now? Okay, they've gotten a lot better with e-stim and working, and that's a patient population that they do work with. And this is, so differential diagnosis, you guys know what that means? You have a whole class in your 3rd year called differential diagnosis. It's huge for PTs right now. It's a fun class to teach. What does that mean? What do I mean when I say differential diagnosis?
The diagnosis that fits pretty closely.
Yeah, well, so what are the possible things that we can figure out by how the patient presents? Okay, so yeah, you can have multiple diagnoses, but you'll see with cranial nerve number 7 that there's a big difference between having Bell's palsy versus having a stroke in patient presentation. So differential diagnosis is just going to be you trying to figure out what are the possibilities for this patient, and what do I know? In the future, in your 3rd year, you're going to figure out treat, refer and treat, all that stuff. But for right now, we're just looking at cranial nerve number 7. And these are, so there's going to be a couple of categories here. This is a frontal section. We're going to start over here on the left. Okay, just frontal section. Here's the cortical region, midbrain, and pons. Okay, and we're going to start out labeling what is normal. So for normal, there is this circle down here represents a person's face. So I'm going to have the top part of their face. There's going to be some eyes here. There's going to be a mouth, a nice big smiley face. Okay, and we can have some eyebrows too, just to see what's happening. Okay, this is a picture of a normal smiley face. So I'm going to use 2 colors to represent 2 different things. The part of the face that's like everything else, all the other cranial nerves. If you want to divide your face into two, there's an upper face division and a lower face division. Okay, so two different parts of your face. So the upper face would be just like your eyes and above, right there. Your lower face would just be your smile, for the most part. Right in the middle. Where it usually is.
So like what if you split?
No, so you won't really see that much of a change in a person's nose, I guess, because it's mostly cartilage. So what I'm looking at is the lack of musculature. So since the nose doesn't have any musculature, you're not going to see it as part of the patient presentation. And what I'm trying to do here is represent the patient presentation. Okay. Let's talk about the thing that's the same. Okay. If we had to draw in, what's the name of the nucleus that is responsible for motor function for cranial nerve number 7? Anybody remember? Yeah, that's your facial nucleus. Good. And your facial nucleus is going to be down here in the pons. And let's draw the normal presentation. So, and the normal presentation here is going to be the upper facial division. So if I'm going to label this is going to be my facial nucleus for the upper face. Okay, so you want to think about the facial nucleus being divided in two. There. Okay. So what I said before, so for the upper face, all the other cranial nerves, they have an upper motor neuron here bilaterally. All right. And what happens is ipsilaterally sends out axons that travel down to synapse here, also synapses with the other side. And then on the opposite side comes down and then crosses over at the level of the facial nucleus to synapse. Okay. The upper face division for the facial nucleus is responsible for innervating the upper face, which would be this part of the face. Okay, so you're looking at, you could look at wrinkling of the of the forehead. You can look at eyebrow falling, or like the eye sort of drooping to the side. That's going to be your upper face division. For the lower face division, you just have one thing happening here, and I'm going to use orange for the lower face division. Okay, this is going to be my facial nucleus for lower face. Facial nucleus for the lower face is only making a synapse, or is being synapsed by contralateral upper motor neurons. Okay, so that contralateral upper motor neuron sends out an axon that travels all the way down to the level of the lower face facial nucleus that decussates at that level. So it's only innervated contralaterally, and then it sends out axons that are responsible for innervating the lower portion of the face in a normal situation. Okay, lower face is only contralateral. Kind of like your standard presentation for motor weakness if you've had a cortical stroke. Okay, upper face, innervated bilaterally, just like all the other cranial nerves. Questions about normal? Okay, this is a normal presentation. Now let's look at what happens in a patient post-stroke. Okay, let's go ahead and draw the a stroke, we've talked previously that a stroke is an upper motor neuron injury. All right? So what's going to happen is the upper motor neuron is going to be wiped out up top. So, for the upper face division, which is red here, I midline them too. Okay, the upper face division, same as before, no differences. I've got upper motor neurons here bilaterally. Ipsilaterally come down and synapse with the upper face division, and then contralaterally come down, decusate, and synapse with the upper face division. Okay, but for the lower face division, in here, I only have one upper motor neuron that's going to be contralateral, travels down ipsilaterally, and then decusates contralaterally. Just what we did before, no changes. Okay. And the upper face division, as I said, is responsible for innervation of the upper part of the face, and the lower face division is responsible for innervation of the lower portion of the face. This is a presentation, so if I had to get rid of the upper motor neuron, I'm going to say that there's a problem here. I'm going to say that's where the problem is. All right. Both of those upper motor neurons have been wiped out. So how do you think my patient's going to look? What's their face going to look like? Ipsilateral or bilateral or contralateral? I see. Contralateral. Right. So what you see, since this side is completely gone, I still have this side coming down for the upper face division. So I'm going to have a normal upper face. And the normal upper face, just nice straight eyes and nice straight eyebrows over here. Okay, for that part. But I'm going to have a problem contralaterally, just like you'd expect motor weakness post-stroke to be. This side of their face is going to be looking pretty good. Contralaterally, they're going to have a droopy face on the opposite side. Okay, so what you see post-stroke, in patients post-stroke, you see the droopy lower face division, but the upper face division looks normal. That makes sense to everybody. So I've lost the upper motor neuron from one side, but the upper face is redundant. It's innervated from both sides. In case there's a problem on one side, that upper side of the face still looks good. Got it? Okay, now thinking about the other possibility when you have what's called facial paralysis or facial droop is a problem known as Bell's palsy. And Bell's palsy is your lower motor neuron injury. Okay, so same situation as before. I'll keep the sides the same. We have the upper face division, facial nucleus, and the upper face has bilateral upper motor neurons. Sends out axons ipsilaterally that synapse ipsilaterally, and the opposite side sends out axons that descend ipsilaterally and then decusate at the level of the nucleus. lower face, and then the lower portion, lower face division has lower face division nucleus, has contralateral upper motor neuron. Axons come down ipsilaterally and then decusate at the level of the nucleus. And for the upper face division, axons come out at the level of the 7th cranial nerve, innervate both the upper portion of the face and the lower portion, so innervate the upper portion of the face, and then axons from the lower face division come as cranial nerve number 7, innervate the lower portion of the face. We got it? So no different than anything we've just done. Everything's pretty much the same. Now, the big difference is going to be where the lesion is. If it's a lower motor neuron lesion, it's going to be down here somewhere, right? So let's just say there's a problem here. And I've lost that. How's the face going to look? Any thoughts? How about this side of the face? Is there going to be any changes over on this side? Nope. It's going to look normal. Okay, so I have my nice eyebrow. I've got my nice eye for the upper face division. And then for the lower face division, I've got my nice smile here. Okay. Now how about the upper face division for the lower motor neuron injury? What are you going to see? Yeah, droopy eye, droopy eyelid. So you're going to look, and the eye is going to be over here, all droopy, right? And the smile in the lower face division is also going to be droopy. Pretty sad looking. This is Bell's palsy presentation. A lot of times when you're thinking about warning signs of a stroke, patients are told to consider facial droop, or facial asymmetry, but you could also wake up with Bell's palsy. The difference is when you look in the mirror, somebody looks at your face, your entire half of your face for that lower motor neuron injury is drooping. Okay, presentation of a stroke, the upper is preserved and the lower is down. That makes sense? Question? Any questions about that? This is kind of an important thing to remember for the future. Okay, let's go ahead and take a 10-minute break. We'll move on to